much. Thank you for inviting me here today to present on behalf of Team Salford. We have been working on this program now for a period of 10 to 15 years, and the attraction of the innovation challenge was that the definition of wastage, which you referred to, was very much in line with the work that we've been doing. And it seemed that we had achieved quite a lot locally in comparison with neighbouring PCTs, which we thought others might benefit from, and so we decided to make this submission. The presentation today will be outlining these points, bullet points that are on the chart here, and I shall work through those one by one. So the challenge for us was to identify causes for the 4% wastage within approximately £40 million worth of expenditure on medicines in primary care in Salford. To reduce wastage, to release resources for reinvestment in healthcare, and to engage both health professionals and patients in the efficient use of resources. So our solution to this problem was a small but efficient medicines management team. I say small but efficient in as much as many PCTs have far more staff than we have. And yet, despite that, we seem to perform reasonably well in comparison with those people, so we must be quite efficient. And we lead the project. We engage GP practices, pharmacies, patients, and hospitals. And I would stress that a lot of our success has come from good teamwork right the way through, from beginning to end. Everybody working together, everybody understanding the agenda, everybody understanding the reasons why we do things, not because it's personal preference, but usually because there's a good evidence base to say that one medicine is as effective as another, one medicine is cheaper than another, but equally as effective. And when people understand the reasons why we want to do particular things, we generally find that everybody buys in. We haven't had any problems of note of resistance at all. We also have a program of annual prescribing reviews with each GP practice in Salford. That's part of the QOF, Quality Outcomes Framework, for the practices anyway, but we use that opportunity to provide an analysis to the GPs of all of their prescribing throughout the previous 12 months. And we discuss in detail which drugs are being used, how they're being used, and where there might be other options. Within that process, there's always opportunities for efficiency and efficiency savings, and we usually leave with an agreement that our facilitators can go into the practices and do some work to help improve performance. We do have assigned facilitators for each practice, so that they're part of the practice team on a daily basis. Perhaps most important, we have planned work streams. We don't just jump around from one thing to the other, think what's coming up next. At the end of each year, or towards the end of each year, we do an analysis of everything that's being prescribed in Salford, and we look at what the current risks are, and also we look at what the new drugs are coming to market, or where a drug is likely to cease to be a branded drug because the patent is expiring and there will be cheaper generics around. We're also aware that companies, when the product is coming towards the end of its product life, might bring in another product very similar to it, but again branded at a higher price with no therapeutic advantage, and we have to be aware of that because again that is a waste of resource. We have to be proactive in preventing wastage before it arises. That means we have to be fully aware of what is happening within the pharmaceutical industry, what is happening in terms of research that's translated into clinical practice, what the NICE guidance is, all those quality outcome frameworks. We have to be very much aware that some of those might impact upon prescribing, and we have to be ahead of the game. If we're not, then we are always reactive to what's gone wrong, trying to put it right, rather than being proactive to prevent it from going wrong. And by doing that, we've reduced the amount of work we have to be reactive to, and we've had more quality prescribing, more efficient use of resources as a consequence. We do rely very much on technology. We use two pieces of software primarily. One's called ScriptSwitch, and the other one is called EPACT. EPACT is the Department of Health's electronic prescribing cost analysis system, whereby whenever a prescription is dispensed, it is entered into their system, and we can interrogate their database and determine which drugs, in which formulations, in which strengths are being used by which practices or even which prescriber over any given time period. So that gives us a really good way of analysing exactly what's going on. And we can see for each practice what the top 10 drugs are, what the 10 most expensive drugs are, what new drugs have come in, whether or not they've been taking note of our advice, those sorts of things. Now, that data is also used by the Regional Drugs and Therapeutics Centre at Newcastle, and they chart that information for us in the charts that we've distributed to you already, showing our performance in comparison with other PCTs, and those are quarterly points on that particular chart. We do also, as a team, utilise the EPAC data to provide a report every month to every practice on the performance on the particular areas of work that they have. The other piece of software we have is ScriptSwitch. This is an add-on to the GP's computer on his desk. When the GP prescribes a drug, in about 10 to 15% of cases, the ScriptSwitch pop-up screen will come up and advise the GP of a safety issue about the drug, of an effectiveness, cost-effectiveness issue, or a clinical effectiveness issue. I have to admit the majority of the alerts are around cost, advising him that there's a cheaper strength, a cheaper formulation, and that has proved very successful. We piloted that about 5 or 6 years ago when ScriptSwitch was being developed. Then we dropped it for a year or two whilst other PCTs were developing it further. We picked it up subsequently. Every practice in Salford now uses it routinely, and it's saving us hundreds of thousands, as shown again on the spreadsheet that I distributed to you. We report monthly to the practices. Each practice is assigned a piece of work which is specific to them. We don't say, right, we're doing this across the whole PCT. We have done that in the past, but now we've had such success with this program that we are able to be more specific with each practice and say, these are the areas of work that you need to work upon. And using that approach, each practice this year has 9 pieces of work that they have to approach, and we are providing them with information on that. 3 of those pieces of work do in fact relate to reducing wastage, which specifically, which is more than they've taken on previously. But they have 3 other pieces of work to address prescribing issues specific to their practice under the incentive scheme. Again, that reduces wastage, and they have to do 3 for the QOF QIP, which will also have the effect of reducing wastage. We do incentivise both prescribers and the pharmacists. The prescribers are incentivised through the QOF scheme and also through the PBC incentive scheme. The QOF scheme is the normal repayment process. The PBC incentive scheme, I'm told the practice average GP gets something like £1,500 before tax, etc., per annum. And the pharmacists, we've only just started this scheme, we only started to roll it out, whereby they signify to the GP, notify the GP, any behaviour in terms of the way patients are handling their medicines which would suggest that there's wastage. Patients are collecting certain types of inhaler too frequently. Patients are not collecting their medications. Patients are returning some medicines for destruction. What we are finding is that in many instances we can't quantify the actual saving, because what's actually is happening is that the GPs are calling the patients in and counselling them and improving the patient compliance so that they actually take their medicines rather than having them destroyed. The savings from that might accrue further down the line if the patient continues to be well rather than being ill, or if the patient is subsequently hospitalised. So all of these things contribute to the reduction of wastage. We give a high priority throughout our work for quality, and I believe this also does help reduce wastage, in as much as if you get things wrong then have to put them right, it costs more. So you might as well get it right in the first time. So we are always alert to the guidance from the NICE, the NPSA. We respond to significant events where things go wrong. We use medicines use reviews whereby community pharmacists talk to patients about their drugs to ensure that they are using them correctly. So our achievements are that we've got practice and pharmacies engaged, we've got work streams going in GP practices, work streams in pharmacies, resulting in prescribers taking action to improve prescribing compliance and concordance with medication by patients. We've got best value saving streams which are successful, and overall expenditure reductions as the number of items prescribed increase. Financial summary I've distributed to you, but the two saving schemes in the last 2 years saved 622,000 and 1.59 million. Our methodology has got a proven track record and proved successful over several years. It could be adopted by any other organisation with responsibility for delivering savings. Planned programmes of work informed by clinical, pharmaceutical and cost issues could be adopted everywhere. A proactive team approach is essential and easily adoptable. The opportunity for spread at the moment for this, I think, is high. There are NHS reforms for commissioning that may result in alternative arrangements for managing and optimising the use of medicines. It's not going to stay the same as it is at the moment. There will be new organisations possibly delivering these sort of services. The way we work could be picked up by these organisations and could be rolled out across the country. What we're doing is not completely unique. It isn't unique, but the way in which we are doing it seems to be more successful than some of our neighbouring PCTs. This is not the total story. We've adopted an approach at the moment of addressing wastage caused by health professionals, the GPs, the pharmacists within the system. The next stage is to bring the patients on board, and we need to develop this into a social marketing exercise, and there are companies out there with whom we are engaging, but of course they need to be funded. So this is as far as we come at the moment. We feel it could be rolled out elsewhere, and there are opportunities for this to be a continuous project over many years. Thank you.